Welcome to our first video on acid-base disorders. Let's begin. In this lecture, we will cover metabolic acidosis and metabolic alkalosis. Let's start with metabolic acidosis. We will discuss the definition, causes, clinical presentation, diagnosis, and management of metabolic acidosis. Metabolic acidosis is a condition with an arterial pH less than 7.35 and decreased bicarbonate levels. Metabolic acidosis is classified into increased anion gap and non-anion gap metabolic acidosis, depending on whether the anion gap is increased or not. In order to calculate anion gap, we need to subtract the sum of serum chloride and bicarbonate concentrations from serum sodium concentration. Normal anion gap is anywhere from 8 to 12 microequivalents per liter. Causes of increased anion gap metabolic acidosis can be remembered by the mnemonic gold mark. First, glycols such as ethylene glycol and propylene glycol can cause anion gap metabolic acidosis because they are metabolized into organic acids. Oxoproline is a toxic metabolite of acetaminophen that can result in anion gap metabolic acidosis. L-lactate is present in the setting of lactic acidosis, while D-lactate is derived from exogenous sources. Regardless, both of them can reduce arterial pH. Methanol is metabolized to formic acid that also induces acidosis. Aspirin is acetylsalicylic acid, and its metabolite, namely salicylate, can cause anion gap metabolic acidosis in the late phase of aspirin toxicity. Please note the early phase aspirin overdose causes respiratory alkalosis due to direct stimulation of medullary respiratory center. We will discuss this concept again when we move on to respiratory alkalosis. Renal failure results in retention of organic acids. Finally, ketones like acetoacetate and beta-hydroxybutyrate can lower the serum pH because they are organic acids. Accumulation of ketones can occur in the setting of diabetic ketoacidosis, alcoholism, and starvation. Let's move on to the causes of non-anion gap or hyperchloremic metabolic acidosis. It is called hyperchloremic because non-anion gap metabolic acidosis is characterized by high serum chloride levels. Causes of this acid-base disorder can be remembered by the mnemonic HARD-AS. First, hyperchloremia or hyperalimentation can result in non-anion gap metabolic acidosis. Hyperalimentation means intravenous nutrition. IV nutrition solutions are rich in acidifying agents such as hydrochloric acid, which result in metabolic acidosis. Addison's disease or primary adrenal insufficiency is characterized by aldosterone deficiency. Normally, aldosterone stimulates hydrogen ion secretion from the alpha intercalated cells of the collecting tubule. Aldosterone deficiency results in retention of these hydrogen ions and therefore metabolic acidosis. Renal tubular acidosis is the group of renal disorders that causes either excessive bicarbonate loss or hydrogen ion retention. Diarrhea causes non-anion gap metabolic acidosis because diarrheal fluid is rich in bicarbonate, which is lost in stool. Acetazolamide blocks carbonate anhydrase in proximal convoluted tubule and therefore increases renal bicarbonate excretion. In other words, it causes pharmacologically induced type 2 renal tubular acidosis. Spironolactone blocks aldosterone receptors. Decreased aldosterone effect causes metabolic acidosis with the mechanism we have already explained. Excessive saline infusion inhibits the renin-angiotensin-aldosterone system. Relatively low concentration of aldosterone then causes non-anion gap metabolic acidosis. Let's talk about the clinical presentation of metabolic acidosis. Symptoms largely depend on specific cause of metabolic acidosis. However, there are several nonspecific findings that almost all patients with metabolic acidosis present with. They usually have hyperventilation due to respiratory compensation. Patient might also present with nausea, vomiting, and altered mental status. We will now discuss the arterial blood gas findings of metabolic acidosis. Metabolic acidosis is characterized by arterial pH less than 7.35 and serum bicarbonate less than 22 milliequivalents per liter. Partial pressure of carbon dioxide is usually decreased due to fast compensatory hyperventilation. In order to find out whether the partial pressure of carbon dioxide falls into the compensation range, we need to use Winter's formula. Once we plug in the bicarbonate value in this formula, we receive a range within which any value of carbon dioxide is considered to be normal compensation. If we suspected metabolic acidosis, we can also obtain blood glucose and ketones to check for diabetic ketoacidosis. Renal function tests such as blood urea nitrogen and creatinine are important to rule out renal failure as the cause of metabolic acidosis. Basic metabolic panel, on the other hand, will reveal not only glucose, blood urea nitrogen, and creatinine, but also any electrolyte abnormalities in the patient. A 45-year-old woman comes to the physician due to severe fatigue for the last 7 months. The patient has a past medical history of Hashimoto thyroiditis. The vital signs show hypotension, tachycardia, and hyperventilation. The physical exam reveals a dark discoloration of the palmar creases. Lab findings are significant for hyponatremia and hyperkalemia. What changes are expected in this patient's arterial blood gas findings? This patient presents with hypotension, tachycardia, and hyperventilation. The physical exam reveals dark discoloration of the palmar creases, while laboratory findings are significant for hyponatremia and hyperkalemia. Considering that she has already one autoimmune disease, her current presentation is most consistent with Addison's disease, or chronic primary adrenal insufficiency. Primary adrenal insufficiency is characterized by low levels of both aldosterone and cortisol. Low levels of cortisol disinhibits ACTH production by the anterior pituitary, which causes increased serum ACTH. Melanocyte-stimulating hormone, abbreviated MSH, is the byproduct of ACTH synthesis and is responsible for dark discoloration of the palmar crease in this patient. Aldosterone deficiency causes hyponatremia, hyperkalemia, and retention of hydrogen ions in the body. However, the anion gap remains normal. Therefore, the patient with Addison's disease most likely has a normal anion gap metabolic acidosis. Management of metabolic acidosis largely depends on the specific cause of this acid-base disorder. Sodium bicarbonate is only administered in cases of severe acidosis when the arterial pH is less than 6.9. If metabolic acidosis is resistant to cause-specific treatment and sodium bicarbonate, we can perform hemodialysis. Let's move on to metabolic alkalosis. We will discuss definition, causes, clinical presentation, diagnosis, and management of metabolic alkalosis. Metabolic alkalosis is an acid-base disorder characterized by arterial pH more than 7.45 with increased bicarbonate levels. Causes of metabolic alkalosis can be divided into those with low urine chloride and those with high urine chloride. Metabolic alkalosis with low urine chloride includes conditions that lead to volume depletion. Volume depletion leads to activation of renin-angiotensin-aldosterone system. Aldosterone, in turn, stimulates hydrogen ion secretion from the alpha intercalated cells and production of bicarbonate ions that leads to metabolic alkalosis. Therefore, causes of metabolic alkalosis with low urine chloride include vomiting, nasogastric aspiration, and prior diuretic use. As a general rule of thumb, the extrarenal loss of chloride leads to metabolic alkalosis with low urine chloride. On the other hand, causes of metabolic alkalosis with high urine chloride can be further classified into hypovolemic, euvolemic, and hypervolemic conditions. Hypovolemic and euvolemic conditions include current diuretic use, Bartter and Gittleman syndrome. Most commonly used diuretics, that is loops and thiazides, block sodium and chloride reabsorption in the loop of Henle and distal convoluted tubule, respectively. This is why they result in high urine chloride. So current diuretic use causes chloride loss in the urine, resulting in high urine chloride. In contrast, the prior diuretic use causes volume depletion, activation of renin-angiotensin-aldosterone system, and reabsorption of urinary chloride. This is why the prior diuretic use results in low urine chloride. Bartter syndrome is a genetic defect of the sodium-potassium to chloride cotransporter, and it mimics the chronic loop diuretic use. Gittleman syndrome is a genetic defect of sodium chloride cotransporter, and it mimics the chronic thiazide diuretic use. Finally, hypervolemic causes of metabolic alkalosis with high urine chloride include primary hyperaldosteronism, Cushing syndrome, and ectopic ACTH production. Hypervolemia inhibits chloride reabsorption in the distal nephron due to a mechanism that is beyond the scope of USMLE Step 2 CK. Primary hyperaldosteronism results in aldosterone-induced secretion of hydrogen ions and production of bicarbonate. Hypercortisolism, that is Cushing syndrome, results in a syndrome of apparent mineral corticoid excess. This is when cortisol activates aldosterone receptors in the collecting tubule and causes metabolic alkalosis with the mechanism that we have already discussed. Another way of classifying causes of metabolic alkalosis is saline responsive versus saline unresponsive. Causes of metabolic alkalosis that are characterized by reversible volume depletion are saline responsive. These include vomiting, nasogastric aspiration, and prior and current diuretic use. On the other hand, genetic syndromes, tumors, and hypercortisolism are saline unresponsive because in these conditions, metabolic alkalosis is not caused by volume depletion in the first place. These include Bartter and Gittleman syndromes, primary hyperaldosteronism, and Cushing syndrome. Here we see the graphical illustration of the nephron. Please note that Bartter syndrome is caused by autosomal recessive defect in sodium-potassium to chloride cotransporter in the thick ascending loop of Henle. In contrast, Gittleman syndrome is caused by autosomal recessive defect in sodium chloride cotransporter in the distal convoluted tubule. Here we see how excess cortisol activates aldosterone receptors in the principal and alpha intercalated cells of the collecting tubule, contributing to hypokalemia and metabolic alkalosis. Aldosterone receptor is depicted by the letter R in the white circle. When activated by aldosterone or cortisol, these receptors stimulate sodium reabsorption and potassium secretion by principal cells and the hydrogen ion secretion by the alpha intercalated cells. Clinical presentation of metabolic alkalosis depends on its specific cause. Symptoms might include vomiting, hypertension, or hypotension. Patients with metabolic alkalosis present with hypoventilation due to respiratory compensation. Let's talk about the arterial blood gas findings in metabolic alkalosis. Arterial pH is more than 7.45, and serum bicarbonate levels are more than 28. Partial pressure of carbon dioxide is increased due to fast compensatory hypoventilation. Generally, respiratory compensation is much faster than renal compensation because respiratory changes are induced by sensing the altered pH by central and peripheral chemoreceptors. We can also measure urine chloride levels in the patient suspected of having metabolic alkalosis. Urine chloride more than 40 signifies renal loss of chloride, while levels less than 25 signify extrarenal loss of chloride. We can also perform diuretic screen if diuretic abuse is suspected. 24-hour urinary free cortisol is measured to screen for Cushing syndrome. Finally, aldosterone to renin ratio will help us diagnose primary and secondary hyperaldosteronism. Let's try a question. An 81-year-old man comes to the physician due to unintentional gain of 5 kilograms over the last 2 weeks. He's also noticed blood in his urine. The patient has been smoking 3 packs of cigarettes per day for 60 years. Physical exam reveals a round face, supraclavicular and dorsocervical fat pads, and increased waist circumference along with thin extremities. A flank mass is palpable on the left side. His laboratory findings are significant for metabolic alkalosis with respiratory compensation, as well as hypokalemia. What is the most likely explanation of this patient's lab findings? This patient presents with unintentional weight gain. He rapidly gained 5 kilograms over 2 weeks. A flank mass is palpable on the left side. This presentation in the setting of extensive smoking history is most consistent with renal cell carcinoma. Renal cell carcinoma can produce ACTH, resulting in Cushing syndrome as its paraneoplastic phenomenon. This patient has a rounded face, also known as moon face, supraclavicular fat pads, and dorsocervical fat pads, that is, buffalo hump. He also has increased waist circumference along with thin extremities. All these findings are consistent with Cushing syndrome. His lab findings are significant for metabolic alkalosis and hypokalemia. Cushing syndrome can cause hypokalemic metabolic alkalosis because excessive cortisol activates the renin-aldosterone receptors and stimulates potassium and hydrogen secretion along with bicarbonate production. Let's talk about the management of metabolic alkalosis. Saline-responsive metabolic alkalosis is treated with volume repletion. We can use intravenous normal saline in cases of severe volume depletion. Management of saline-unresponsive metabolic alkalosis is specific to the cause of this acid-base disorder. This is the algorithm of causes of metabolic alkalosis. Please pause the video and take a moment to consider this algorithm. Here we see the Davenport diagram of acid-base disorders. This graph will be explained again on our next lecture on acid-base disorders. The x-axis displays the different arterial blood pH values, while the y-axis displays arterial plasma bicarbonate values. In general, anything to the right of 7.4 is considered alkalosis, while anything to the left of 7.4 is considered acidosis. pH of more than 7.4 with high bicarbonate and high partial pressure of carbon dioxide corresponds to metabolic alkalosis. In contrast, pH more than 7.4 with low bicarbonate and low partial pressures of carbon dioxide is respiratory alkalosis. Anything in between these two conditions is mixed alkalosis. pH less than 7.4 with high bicarbonate and high partial pressure of carbon dioxide corresponds to respiratory acidosis. In contrast, pH less than 7.4 with low bicarbonate and low partial pressure of carbon dioxide corresponds to metabolic acidosis. Anything in between these two conditions is mixed acidosis. Here we have the algorithm showing all the acid-base disorders and their potential causes. Please pause the video and consider this algorithm. A 74-year-old woman is brought to the emergency department due to confusion and vomiting that started 4 hours ago. Her son found a suicide letter next to her bed. The patient complains of ringing in her ears. She has vomited 3 times en route to the hospital. She has a past medical history of hypertension and peripheral artery disease treated with enalapril, nifedipine, and aspirin. She had gastroenteritis with watery diarrhea 1 week ago. Her vital signs include a blood pressure of 100/80, heart rate of 100 beats per minute, and respiratory rate of 30. Arterial blood gas show pH of 7.42, bicarbonate levels of 16, and PaCO2 of 25. Her lab findings are significant for sodium levels of 139 and chloride levels of 95. Which of the following is the most likely cause of the patient's acid-base disorder? A. Medication toxicity, B. Vomiting, C. Diarrhea, or D. Hyperventilation. This patient presents with vomiting and ringing in her ears, that is, tinnitus. She takes aspirin as well. Her son found a suicide letter next to her bed. Therefore, she likely overdosed on one of her medications, presumably aspirin. Aspirin overdose is further supported by the fact that this patient has a mixed acid-base disorder with a normal pH. Her bicarbonate levels are low, indicating metabolic acidosis, while her partial pressure of carbon dioxide is inappropriately low, indicating concomitant respiratory alkalosis. In order to calculate appropriate respiratory compensation for metabolic acidosis, we should use Winter's formula. Based on Winter's formula, this patient's partial pressure of carbon dioxide is supposed to be anywhere from 30 to 34. Her actual carbon dioxide pressure is 25. Additionally, her serum anion gap is more than 12. It is actually 28 because we need to subtract the sum of her chloride and bicarbonate levels from her serum sodium. Mixed respiratory alkalosis with high anion gap metabolic acidosis is best explained by aspirin overdose. Therefore, the correct answer is A, medication toxicity. Here's a slide reminding us that salicylates cause mixed respiratory alkalosis and high anion gap metabolic acidosis. Let's discuss why the other options are incorrect. Option B is incorrect because isolated vomiting results in metabolic alkalosis rather than mixed acid-base disorder. Option C is incorrect as well because isolated diarrhea causes non-anion gap metabolic acidosis. Finally, option D is also incorrect because isolated hyperventilation results in respiratory alkalosis. And that concludes our first lecture on acid-base disorders.